floor is yours.
Good morning, everyone, and thank you very much for coming this morning. I'm going to be speaking generally about epidemiology of HIV and starting out with the United States and sort of bringing it home toward North Carolina and eastern part of the state. Um, I will not discuss sort of my research and ongoing research interests here, but if there's anyone interested, I'd be more than happy to talk to you about that after the presentation. So our objectives again are to discuss the epidemiology and recognize the disparities in HIV that'll become apparent during the discussion today. And describe some initiatives that North Carolina has taken up as a state to address these disparities. And then also, finally, to identify how ECU can help address the disparities in HIV care in North Carolina. So many of the slides initially are from the CDC slide sets, and these are the most recently updated slide sets regarding HIV surveillance through 2008. So just starting out here, diagnosis of HIV infection among adults and adolescents. You have about 70%, 72%, the vast majority of cases in men are from male-to-male sexual contact. In women, you see that flip to 84% secondary to heterosexual contact, which is even emphasized more in the South and in North Carolina. Over the years, what we've seen is that there's been a shift in sort of the diagnosis of AIDS, and the CDC does differentiate in these slides between HIV and AIDS, given that AIDS is a diagnosis that's made clinically or by laboratory values, where your CD4 count is under 200, or you have an AIDS-defining illness. So AIDS diagnoses among adults and adolescents from 85 through 2008. Initially, at the beginning of the epidemic, you see that about 80% of the cases were in men who had sex with men, and then heterosexuals were sort of here, sort of hiding in the background, and you had some injection drug use. Well, over the years, the male-to-male sexual contact as a risk factor for HIV or the cause of transmission has decreased somewhat. In about 96 here, you see where there's a shift, and that was when the antiretroviral therapy was initiated. So you see this sort of decrease in the transmission and then sort of a lull and then a little bit of an increase here. Meanwhile, while heterosexuals were sort of, I guess you could say, flying under the radar there because it was thought primarily to be a MSM disease, you have sort of decreased percentage of cases in that group, and that has increased dramatically over time. And injection drug users here are another big transmission category risk, and that sort of has changed and decreased over time, and that's predominantly due to the needle exchange programs and things like that that are in the major cities. And so when we look at the AIDS diagnosis by race and ethnicity, we also see a shift where it was initially predominantly a disease of whites, and then now we see a much more predominance of blacks or African Americans holding the burden of disease, and that's throughout the United States and particularly in North Carolina. If you focus over the last sort of time frame between 2005 to 2008, and this is HIV infection, you see that blacks have sort of held steady around, holding around 50% of the cases, and sort of the same thing sort of holding steady around here. You can sort of imagine the teeny weeny, maybe perhaps decrease in whites and a slight increase in blacks, but generally it's about 50% over the past several years, and that's true today. So looking at the diagnosis of HIV infection according to race and sort of splitting it up between males and females, here you see that, again, blacks bear a disproportionate amount of disease for both males and females. You have blacks comprising about 12% of the U.S. population and comprising about 45% of new cases of HIV in males and 65% of cases in females. Here we have whites, and then here's Hispanics or Latinos. And Hispanics, that group comprises about 15% of the U.S. population, so they're sort of on par in terms of their representation in HIV. So diagnoses in terms of risk category, again, male-to-male sexual contact is a predominant risk of transmission, and then sort of after that they combine male-to-male sexual contact in combination with drug use. That can sort of be included in this group. And then sort of the next big risk factor is heterosexual contact. And when we say heterosexual contact, we say a high-risk contact, meaning that they're engaging in sexual activity with someone who is either at high risk for HIV or known to have HIV. So when we look at diagnoses rates of HIV, in 2008, we have sort of this, and this is sort of all comers populations, 37 states, and these 37 states are just the states that have had confidential name-based reporting systems since 2005 only. So some of these states now have been included, but this is just the states from 2005 onward. So sort of the U.S. average is 23.6 cases per 100,000. In North Carolina, we're just a little bit above that average at 29.8. And sort of you see that the breakdown here in rates is that the highest rates are in orange, and that's represented very heavily here throughout the South. So again, I guess I'm sort of reiterating to you here that deaths, well, actually, so we talked about HIV, AIDS, and the sort of long-term outcome of HIV and AIDS. If blacks are being more affected with AIDS, and they're going to have increased risk of death. So deaths due to HIV here is sort of stressed here in the black or African American population. There is sort of this growing group of what they consider to be multiple races, and that's people that are sort of classifying themselves as mixed races, or we don't have the information for their races. And you'll notice here also that the Native Hawaiian and other Pacific Islander group, and then the American India, Alaska Native groups, they're going to be represented in the slides, but there's a very low N for these cases. So some of the sort of percentages and prevalence may be exaggerated in some of the upcoming slides. So the year end of 2007, and this is rates of adults and adolescents that are currently living with HIV at the end of 2007. So again, here the sort of U.S. average is 336 cases per 100,000. In North Carolina, we're at about 307. And again, sort of on par with the sort of dark South area where HIV is sort of a really big problem. So in terms of, I think we've sort of gotten the picture so far that it is particularly a striking epidemic in the African American community. So from 2005 to 2008, blacks accounted for 49% of the total cases of HIV, 64% of the cases of HIV in women, 66% of the infections that were attributed to heterosexual contact, and then 66 of diagnoses made in children under 13 years of age. And some of those are congenitally transmitted. And in 2008, again, 50% of the diagnoses of HIV infection were among blacks. So there is a difference when you look at transmission category by race and ethnicity. So what I'm pointing out here is that high-risk heterosexual contact and male-to-male sexual contact. Male-to-male is in yellow, and high-risk heterosexual contact is in pink. So in the African American community, although male-to-male sexual contact predominates all of the different races, you'll see that in the black community, that heterosexual contact accounts for a larger percentage of cases. So when you look at AIDS diagnosis, again, this is the end stage of HIV disease. You have number of diagnoses on this end, and then the percentage of diagnoses, and this is in all minority races and ethnicity, excuse me. And so you had a peak here, and again, sort of you're always going to see that slight drop in 1996 or around about then when we started ART. But again, you still have this sort of steady increase in diagnoses made in minorities. And this is sort of graphically represents that. And this alludes to what I said earlier today, that African Americans here make up 12% of the U.S. population, yet account for 49% of AIDS diagnoses. Whites make up 66% and account for about 30% of AIDS diagnoses, and then Hispanic Latinos 15% and account for about 19% of AIDS diagnoses. So looking at the rate of AIDS diagnosis among blacks in the U.S., and particularly again here in North Carolina, so this slide is among blacks, and you see that the total rate sort of average for the United States is 61.3 cases per 100,000. And North Carolina is at about 50, which is slightly lower than the U.S. sort of average rate. But if you compare that to whites, you'll see the difference, where the U.S. average is 6.2 cases per 100,000. In North Carolina, it's about 5. So apparently, race also plays an impact on survival after AIDS diagnoses. So here again, using the same sort of color scheme, we have whites in yellow, Hispanics and Latinos in green, and African Americans in pink. And so there appears to be a sort of decreased survival in the minority groups. Now, again, this is sort of where the issue comes up, where there's such a low N in terms of numbers. So this Asian, Indian, Alaska Native group had a very low survival rate, but that is probably because there were such a low number of cases. So HIV in the southern United States is also sort of unique in terms of its transmission and things of that nature, which I've sort of pointed out so far along the way. This is how the CDC designates the regions of the United States. So when you think about sort of regional differences, there are a lot of ways to characterize populations, and many people use urban and non-urban areas. The CDC uses these MSAs, or metropolitan statistical areas, and that's defined by the Office of Management and Budget. And it sort of simplified is based on the population in the area. So greater than 500,000, 50,000 to just under 500,000, or less than 50,000 is considered non-metropolitan. And this would generally correspond with non-urban areas. So generally, in all areas, in all states, most of the diagnoses of AIDS comes from the sort of major or large metropolitan areas, and that's designated here. But you can also see down here that these smaller metropolitan areas and non-metropolitan areas, the diagnosis prevalence is increasing. And then again, we're looking at specifically at the South, which has a smallest sort of percentage of cases coming from the very large metropolitan areas, but the largest number of cases coming from non-metropolitan or rural areas. And I just wanted to point out here that in 2007, that the reported cases of HIV in non-metropolitan areas, North Carolina had the highest absolute number of HIV cases in the country coming from non-metropolitan areas, which is significant, obviously, for us. So when we look at sort of this again, but breaking it down between male and female, in the South, again, as we said, always you'll see that MSM is the highest number of cases, but compared to all the other regions of the United States, there's a much higher cases due to heterosexual contact in the South. And then if you look at the same thing in females, I mean, it's apparent there. So when we talk about AIDS specifically, again by the area of residence and region at the year end of 2007, across the board you'll actually see that the South had the highest number of cases from both the large metropolitan areas, the smaller metropolitan areas, and the non-metropolitan areas. The rate was slightly higher in the Northeast, even though they had a smaller number of cases. And so this just shows the percentages of AIDS cases among adults, and again, sort of stressing that the South has the highest percentage. So looking at North Carolina in particular, I sort of made this division line here to signify the difference between the eastern part of the state and the rest of North Carolina. But these are rural and urban county designations, and this is based on census data. And you'll see that basically eastern North Carolina is largely rural. And there are degrees of how rural and how urban it is. So this is sort of the continuum that represents, and this is, I think, updated as recently as 2007. So you'll see that sort of this darker area here represents this sort of top half. So most of the counties in the eastern part of the state are greater than 50% rural. So when we look at the impact of HIV in North Carolina as a state, in 2008, North Carolina ranked 10th among all 50 states in AIDS cases diagnosed and 11th in the nation for estimated persons living with AIDS. And this is from a different source, so when they say AIDS, they mean all HIV and AIDS diagnoses. So number 10 in the United States for HIV and AIDS diagnoses. In 2009, blacks accounted for 69% of the adult and adolescent HIV diagnoses. And the HIV rate for black women is 17 times greater than the rate for white women, and the HIV rate for black men is 9 times greater than that of white men. In North Carolina, from 2008 onward, the rate of new infections has surpassed the national rate by greater than 40%. And women and African Americans have incident rates that are higher than the national average. In 2008, 26% of HIV diagnoses were considered late, and I'll sort of go into why that's important for us. So there is a slight difference, again, when you're looking especially at North Carolina, and this again points out the transmission categories. So when you have MSM, sort of in the country, it's between 50 and 60%. In North Carolina, it's a little bit less, with 41% accounting for MSM, and then 27% due to heterosexual contact. And then looking at North Carolina specifically by race, again 66%, and blacks 28%, and whites. So late testing for HIV is usually defined either by lab or clinical data, meaning that you are testing for HIV at the time when you already have developed AIDS, meaning your CD4 count is under 200, or you have an AIDS-defining illness. In the literature, you'll see it defined based on time. So if you have point A where the patient is diagnosed with HIV, and then point B, they develop AIDS, and if that time period is generally, the time period is less than 1 year, then they're considered to have been diagnosed late if they progress from HIV to AIDS within 1 year of diagnosis. So the ramifications of late testing are pretty important. Particularly, it increases personal morbidity and mortality. We know that persons who are diagnosed with lower CD4 counts and higher viral loads tend to have worse long-term outcomes. It increases the likelihood of transmission. The CDC estimates that 21% of the persons who are unaware of their HIV status are responsible for about 54 to 70% of new infections every year. And there have been studies that have shown that knowledge of HIV infection promotes condom use and adoption of safer sexual behaviors. Also, it obviously has a significant economic impact in the U.S., which we've seen sort of in the inpatient wards here in the hospital, that the direct care costs are about 200% higher in those who are diagnosed late due to complications secondary to AIDS. Some researchers suggest that late testing is simply missed opportunities for earlier testing. In South Carolina, they did a sort of large study that showed that about 41% of patients in their state were diagnosed with HIV were considered to be diagnosed late. And 73% of those late testers have visited a healthcare facility within 6 months to 5 years prior to their diagnosis. And because about 80% of these visits were not related to what people would generally consider to be HIV-related illnesses, they were not tested at the time of their initial presentations. And the late testing rates in North Carolina is about 27%. In Eastern North Carolina, it's about 32%. Nationally, that number is also about between 31 and 33%. So looking particularly at Eastern North Carolina, between 1997 and 2007, the fitted HIV mortality rates have been decreasing but are still 39% greater than the rest of North Carolina in 2007. And during that period, racial disparities also increased slightly. So again, here's the state. You have death rates from HIV in North Carolina, and this is between 1999 and 2001, but these numbers are pretty fairly consistent through now. So the darker the shaded areas is the higher the rate of death, and you can see in the eastern part of the state the rates of death for HIV are much higher generally than the rest of the state. And this data comes from the Center for Health Services Research and Development here at ECU under Dr. Mansfield, just showing the trends in mortality rates for Eastern North Carolina, the rest of North Carolina, and then North Carolina as a whole. So Eastern North Carolina is designated in the blue here, where you see sort of decreased overall in mortality, but there's still a pretty marked difference between the eastern part of the state and the rest of the state. So what can we do? So the short answer, at least initially starting out, what we can do today, what we can start working on is testing. The current CDC recommendations for screening that were revised in 2006 calls for routine screening of patients in all healthcare settings. And generally this is accepted in places where the prevalence of HIV is greater than 1%, which here in North Carolina it is. And this is based on the opt-out sort of paradigm where you are going to be tested. The patient will sign a general consent for care in the hospital and or wherever they are in their primary care office, and they can be informed or asked if they would like to have an HIV test or told that they're going to have an HIV test, and they have the option to say, no, thank you, I don't want it. The problem with this recommendation is that it's just simply not being carried out. And then the CDC also recommends at least annual screening for persons at high risk for HIV infection. And again, those would be persons that, like we described, that men who have sex with men, IV drug users, persons who have multiple partnerships or are switching between partners. They should be tested, at the time of their ending one partnership and starting another. And this at least annual screening should be determined by the primary care physician or the person taking care of them in terms of the timing or the intervals. Separate written consent based on the revised recommendation is not required. However, this is a recommendation and it is not a law. So each state and each county, each hospital actually has the right to continue to reserve the right to have a separate written consent form, and that can sort of pose some barriers when it comes to consenting patients for testing because of the time that it takes. And then also part of these revised recommendations that prevention counseling is not required, neither pre-test nor post-test. The CDC is holding panels right now that are going to put out recommendations regarding screening in non-healthcare settings, which will be interesting because they're sort of going to be basing their recommendations on research that's currently being done. So some known barriers to HIV testing, which I've picked out from the literature that apply most to us, are the lack of routinized testing, lack of perceived susceptibility, lack of providers' recommendation to test, and then emergency departments. So first, the lack of routinized testing. Some patients, particularly in the older age groups, indicate that if HIV testing was considered a routine part of their care, then they would easily and quickly accept testing, but because they feel like it's only offered if they've had a risk event or something of that nature, then they're less likely to test for that reason. Many patients, because of lack of education, have this perceived susceptibility level that may be lower than what in fact they really are in terms of their risk behaviors. And most patients across the literature, and I've noticed this in adolescents, in older men, in men in large urban cities, that say if their provider recommends that they have the test, they'll have the test. If it's not brought up or not initiated by a provider, they'll be less likely to test or request a test to be done. Emergency departments have sort of classically been a barrier because of the inherent risks. When you provide a test and the test results are not immediately available, then it would be difficult for the physicians that are working on shift-based work to offer the test to persons who come in the departments and not have the capacity or the staff or the ability to follow up on those tests and provide the results to the persons who were tested. So just some information on how we have been doing in North Carolina in terms of testing, and this comes from the State Health Department. In 2009, 276,000 tests were performed. 93% of those testing were considered conventional, which is the standard blood draw. The other percentages were for the rapid testing, like the oral quicks. About 60% of those testings were done in the health departments, and that's the STD clinics, the TB clinics, the family planning clinics. About 14% was done in correctional settings. North Carolina has particularly been a model where we have guidelines regarding testing, that all inmates be tested in prisons, and that is using the opt-out paradigm again. But that's only in prisons, and that's not in jail settings. 6% of the tests were done in outreach or community settings. So the positivity rates for the new cases that were found in 2009, obviously, the DIS, or the disease intervention specialists that go out and do contact tracing for positive cases, had the highest positivity rates. But also hospitals and private MDs had high positivity rates, which is one, an indication that we're probably testing people who we consider to be at higher risk, but two, that we have access to the population that needs to be tested, and probably could scale that up a bit. Positivity rates were highest in men, particularly in black men. What we see is that women generally have higher contact to healthcare due to childbirth, and being that HIV is considered a routine part of screening during prenatal care, they're more routinely tested than men. And then in terms of patients that were positive, the highest rates were seen in persons who described having sex with the HIV positive partner, either whether they were known to be or not known to be at the time, and that is both heterosexual and male sexual contact. So some initiatives that North Carolina has undertaken include some of the following. The first is an expanded HIV testing that was initiated in October 2007, where they sort of increased testing, particularly in certain venues, and again, like we described, the jails and prisons, STD clinics, emergency departments, and even offering incentives in emergency departments for testing, and then community health centers. The opt-out rule was changed, and the opt-out rule change was passed in 2007 to allow health departments to use the general consent forms. So again, like I said, there was no sort of strict rule or law saying that you didn't have to use the consent forms anymore, and the health department sort of adhered to certain guidelines, and now they're free to do testing without specific HIV consent forms. The Get Real, Get Tested campaign is statewide in North Carolina and launched in 2006. It's a media campaign that involves both radio commercials, television commercials, and billboards. They also have a toll-free hotline where you can call and get information on local testing centers. Another sort of large project in the state is Project Commit to Prevent, and this is focused on college and university students with a special emphasis on minorities, to encourage the universities to expand their prevention and risk reduction educational programs on the campus, integrate testing programs, enhance the capacity of the campus health services to provide counseling and testing, and then also to strengthen the linkages between the universities and then providers that can care for HIV and STDs outside the campus. The Health Education and Risk Reduction Program is very large and has a lot of sort of sub programs under it, many of which we are involved in here at ECU, but it's to reduce the rate of HIV in targeted populations and targeted areas. And these services are particularly prioritized for people living with HIV and AIDS, heterosexual contacts, men who have sex with men, and IV drug users. So when I say goals, I'm really talking about my personal goals for what I would envision here in the state and in the South and in the nation to eliminate risk-based testing, because we know that we're missing too many patients with HIV with just risk-based testing alone, and move more towards routinized testing like the CDC recommends in both high and low risk groups, meaning that you recommend screening to all your patients, particularly getting a sexual history to know if you need to offer screening more frequently, annual screening, or even more frequently than that. Expand our testing to both healthcare and non-healthcare settings. Some places you may run into barriers in terms of offering testing, depending on, if it's at a community center versus a church and things of that nature. So having some rules and regulations regarding how we should pursue testing in non-healthcare settings. And then special considerations to encourage testing of men, particularly heterosexual men in Eastern North Carolina that we know are presenting late for care. There's many targeted campaigns, again, with the MSM population, but much less so with heterosexual men in Eastern North Carolina, who may generally just not access health care at all. So in terms of what we can do here at ECU, the Division of Infectious Diseases obviously plays a critical role in our outreach programs and community education and testing. We have health educators that go out routinely to many different venues, and this ranges from colleges and universities to some of the migrant worker camps to the YMCA and things of those natures to encourage testing and education. We offer free testing. If you're a patient of ours with HIV, you can bring your partner in and have them tested. And then, a part of this that I sort of have left out of the presentation is, okay, well, what happens after you're diagnosed with HIV? Knowing is part of it, but then being linked to care, and then staying in care is the other part that's very critical. And we have a linkage and retention coordinator through our clinic that serves that purpose. So for the Department of Internal Medicine, essentially, this is our sounding board, essentially, for encouraging testing both in the inpatient and the outpatient settings, both on the patients that you admit, that you see every day in the hospital, when you're consulting on other services, on behalf of medicine to encourage HIV testing, and then in your general outpatient general medicine practice as well. We want to continue working with the emergency department. What it will require essentially is staffing to follow up on testing results, and that's something that we can prioritize in our division to encourage that there just be more STD and HIV testing done in the emergency department where we have access to the patients. And then in terms of coupled screening and outreach programs, what I mean is that there are so many initiatives in terms of focusing on chronic illnesses here in Eastern North Carolina, ranging from diabetes, hypertension, obesity. HIV is now a chronic disease. So coupling HIV screening and education and prevention with the similar programs for primary care services would be really optimal in terms of reaching the same population that we're concerned about. And that's it. Any questions? Yes.
So you mentioned the CDC recommendations that prevention counseling is not required. Any particular reason why? Is it in some way barrier to routinized testing?
Yes, it was studied in the literature that the prevention counseling was a barrier on the behalf of the providers to initiate testing because they didn't feel like they had enough time to sit down and talk with the patient and go over all what was essential. That recommendation sort of is removed, so to speak, but that absolutely doesn't mean that it shouldn't be done. So anytime that we test a patient, we'll, inherently are going to do some type of risk screening and discussion about prevention and things like that. Any other questions? Yes.
Have the policies and procedures here at PCMH been changed to an opt-out? Because 6 months ago I had an issue where the policies and procedures still said it was an opt-in, and I contacted someone and they said they're going to look at it and change it eventually.
Well, I just started in July, but as far as I know, we have an opt-out testing. When you sign the general consent, that includes HIV testing. So there should not be any extra consent form here at PCMH.
And I looked it up in the policies and procedures on our website, and it was listed as 6 months ago as a opt-in.
Opt-in.
Mm-hmm.
Which
I don't know.
policies and procedures is this?
It was on the home page for the UHS, and then I went to the policies and procedures, and it was actually pointed out by one of the nurses on Tucson, and it's still written there in black ink that it's opt-in.
The web page that you're referring to was last updated in 2004. We brought this issue up numerous times, and the nurses still reference it and still refuse to draw HIV testing on certain areas without a specific consent form that we no longer even have. So,
Is there a sort of panel or anyone that's addressing that? I volunteer myself. If there's anyone.
Probably we have to bring it best practices and changes.
I think it's just, thank you for mentioning that.
Yeah.
Our two staff medical director is a member of the general medicine division, and so that's going to be the quickest way to educate that part of the hospital.
Okay. Two
There
South
are
Carolina.
physicians in emergency rooms also who have said the same thing, and I think we have to put it as a best practice in the hospital where everybody can look at it and also becomes a rule. The other important thing is very nice presentation by the way you've done. Everybody has to, for the house staff especially, have to understand the importance of early testing. Nowadays, we are saying that a person who has been diagnosed with HIV at the age of 20, if his CD4 count at that time of diagnosis is about 500 or maybe 400 or so, life expectancy is almost as normal as it can be, about 61 years. But if your CD4 count is around 200 and below, things go downhill. It is extremely difficult to convince even to give people medication because, they have to have an OI medication in addition to the HIV treatment. Things happen. Something happens. Or entourage. You add look at CMV, you add another encyclopedia. Things don't look right starting there. And there are people who never respond in their immunologic status to the CD4 count, even though their viral load is suppressed. So it is very critical for us to not be judgmental and be inclusive in HIV testing almost for everybody.
Yes.
What are we doing to be proactive in the rural settings and find out who has AIDS, who don't have AIDS? Because I travel around North Carolina. I'm from the rural area. I'm finding pockets out there of people having AIDS. No one knows they have AIDS. And I just discovered a community, in my community, where almost everyone uses drugs. Drugs rates are incredibly high in the rural settings, and it's increasing. And I found a whole community. They tell me that infected with AIDS. I talked to the ministers in the area, anyone that's get to these populations unless they go for healthcare. Some of them go to healthcare until too late. So I just want to know what's what we're doing out in the rural counties.
Well,
Trying to address this issue.
so ECU obviously is a part of the larger sort of collaboration of universities that are in the North Carolina area. Obviously, we have sort of, I guess, the most influence in the eastern part of the state. But our division has outreach programs, and Dr. Campbell is here that can sort of discuss more a little bit about that if you're interested. But we have outreach programs that go into rural communities. I have 2 grants that are pending that will enable me and our staff and graduate students to go out further into rural communities to encourage testing. What we have found, and I don't actually not generally, but what has sometimes been found in rural communities is that there are a lot of resistance to having the big universities come in, and it feels as if they're being targeted. That our community has high rates of HIV. Where are you getting this information from? Why are you coming here? Why don't you go there? Also, a lot of the places that we would really like to target that we can reach, for example, I talked a lot about blacks in these communities, are churches, and there's also some resistance on behalf of, spiritual organizations to discuss sex and sexuality and encourage HIV testing and have those types of programs. So there are lots of barriers, I would say, to sort of overcome it when it comes to that. Would you have anything to add, Dr. Campbell?
Other than that, that's a very, very slow process. We've been very active with that as a university, representing the university for about 3 years. We have several programs doing that, but we also only have 3 outreach workers. So it's just a process of getting those things funded. And up to 3 years ago, we had none. So we continue to work on it very hard.
There are quite a few community-based organizations. I met with some of them who are very active in these communities. Go down to Lake County, County, and they're doing great work. And I think I would suggest you get those community-based organizations. You get a lot more success.
They do work, and they in terms of personnel, they may have the capacity to do testing, but they don't have the funding in terms of government support or university support to administer testing.
Now, look, you don't want them to administer testing. We need us to get with them and bring our ability to do testing and let them do the work as far as connecting with people in the community.
Yes, we've definitely been doing that.
There's about like 30 or 50 community-based organizations in North Carolina. I met with them about 2 weeks ago through the Illinois State Medical Society, and they're really interested in working with the medical community and getting these things done. But I can help get you connections.
Please, I love that actually. Yes.
There are a number of HIV positive patients that are out there in the region that we would see that grew up here, contracted their disease somewhere else, got really sick, and then moved back here and presented a wonderful amount of data that was there. Do you have any data that speaks to that diagnosed in another state and then comes back here with very advanced disease, and then we're trying to pick up the pieces and treat these folks? I know you guys see them in your outreach clinics. I think you didn't say enough in your talk about the wonderful outreach clinics that you guys have as a guy who's practiced in another town that y'all came to. Those are wonderful.
Thank you. For my own data and looking at HIV diagnosis in eastern part of North Carolina, in one of my projects we looked at persons that were diagnosed and got the records from the health department. So when you're tested, it's reportable. The simple way to do it is to ask the patient, have you been diagnosed somewhere else, essentially, and not include them into the literature or the information that you provide. In terms of when someone returns back here, generally it is not reported again to the state because they come in with the known HIV diagnoses, and what we do is initiate CD4 and viral load testing. But again, that's not a foolproof method of making sure that those people aren't counted in the statistics.
What I would say from personal experience is that I have seen an increase in, the other providers can talk about this, I have seen an increase in the number of people who are originally from North Carolina and moved away and were infected and then have moved back. And then we have a pretty
Are there any other questions? Okay, well, thank you. I appreciate your time.